Hi, everybody. We are going to cover palliative care and hospice today. This lecture is a little bit short so that you've got some time allocated to work on your assignment. That is the film and hospice assignment. So we will get this information covered and presented for you, and that should give you a little bit more background on that for that assignment as well. So palliative care is basically an approach that improves quality of life of patients and their families. It provides some relief of pain and other distressing symptoms. It doesn't intend to hasten or postpone death, but in fact really focus on quality of life and comfort. It offers a support system to help patients live as actively as possible, and it also helps the family cope with the patient's illness and their own bereavement needs. It should positively influence the course of illness, and it is applicable early in the course of illness in conjunction with other therapies and treatment. This patient can still have chemotherapy, radiation therapy, they can have surgery. There's no limitations on palliative care. It's just a way to really help focus on quality of life. Hospice, on the other hand, is a program designed to provide care for those who are terminally ill. They have to have been determined to have a terminal illness, and that's defined as having a prognosis of 6 months or less. Now, we know that that isn't always the case with everyone because we can't definitively define or know exactly when a person is going to die, but given the symptoms and the level of frailty of the individual, physicians can make a fair guess. Patients can stay on hospice longer than the time frame that is provided, that 6-month time frame, or they may actually pass away in just a couple of days. So the time frame that patients are on hospice varies quite a bit. Hospice services are covered by Medicare and Medicaid and most private insurance plans with very little to no expense to the patient, but the housing costs still need to be covered by that patient. If you have a hospice facility, like the example on this slide says Providence Hospice, and they will also help determine eligibility for coverage, and it doesn't matter whether that person can pay or not. They're going to make sure that their care is covered. And again, bereavement support for families provided. So it's important for you to review the stages of grief, and there are a couple different models that portray grief. This one is for, let's see, Kubler-Ross's stages of grief. It's a pretty basic stage of grief model, and it goes through denial, anger, bargaining, depression, and acceptance. So the crazy thing about this is it's not linear. Patients and family members can move between these stages. While they may move linearly through the stages, they may also bounce back and forth depending on their level of understanding and what they hear. I think it's also difficult to understand for a lot of people when they go to the hospital and the doctor, he's like, well, things are looking pretty good. Well, they might be looking good in that she's not throwing up and having a lot of pain and those types of things, but that doesn't mean that that patient still is going to continue to live, that her or his prognosis has been extended beyond 6 months, and that could be just really confusing for people. So it's important to communicate effectively with the patient, family, and interdisciplinary team. We want to strive to improve that communication between all members, and probably most importantly is to discuss end-of-life preferences. Advocate for the patient and make sure you let others know what their wishes are or were, and also display some sensitivity to cultural and spiritual beliefs, customs, things that the individual or family may need to do in order to help their own bereavement. So it's also important to recognize your own feelings so that you can then set them aside and address what the patient is needing or the family is needing. So if you think about a couple of examples that I've been involved with, I've seen a patient who had a very strong Christian faith. The husband had been on a balloon pump device in the ICU for over 3 months. We couldn't turn the drugs down that were keeping his heart working or pull the balloon pump and remove it. His heart just wasn't able to do anything on its own. And it was really difficult for the family members because he was not very old. He was in his 50s. He had kids who were 19 or 22. It was really, really hard for the family to accept that this wasn't going to work anymore. And the patient made a decision to have things turned off. And you can turn a balloon pump off and you can turn those IVs off, but that doesn't mean that they're going to pass away right away. But you also want to make sure they're comfortable during that process too. And so when we turned those devices off, we administered some pain medication so that the patient wouldn't feel the shortness of breath and that type of distress while their heart was spending the last-ditch effort to try to keep things going. But the family didn't understand why we would give pain medication, even when we explained what it would do to help them feel more comfortable. They thought that it would most likely speed the process of death, when the death is going to happen inevitably, and the pain medication is to help that person be comfortable during that process. So it's a process that you have to go through and get individuals to talk about their feelings and help them understand what's going on as well. We have a case where individuals who were of some type of Asian descent, and I don't remember exactly what, but they have spent time after a death wailing and singing, and that was how they, particularly the women of this particular culture, expressed their grief. And then we had another case of a young man who was probably 17 or 18 who had been in a high-speed chase with the police. And that individual ended up crashing his vehicle and had an extremely severe head injury. When he passed away, the family members were Hispanic, and they wanted the body to stay in place in the ICU in the room for a certain amount of time, like 48 hours, I think. And at that time, we were super busy and we needed the bed really bad. But we had to find a way to find a good place in the middle so that we could move the patient in a way that respected the beliefs of the family and the patient, so that everyone would be satisfied. And what they ended up coming up with was the funeral home would come directly to the unit, which usually we would have the body transported to the morgue, and then the funeral home would come and get them. But the funeral home came directly to the unit to help. We got him transferred to the cart, and the family members kept their hands on him while we did this whole transferring process, and rode in the back of the hearse with the patient to the funeral home. And then they set up an area for them there so that they could grieve in the amount of time that they needed to do that. So you can see that there's a lot of different ways grieving can be expressed, and that's just a handful of methods. I'm sure you guys have seen or experienced other ways that might be different than these, and you can share that if you would like in the discussion area or not. It's totally up to you. If you feel like sharing, that would be fine. I know that some cultures will also celebrate a death and do that from either a small family gathering to a bigger type party. So there's a lot of different things, and we need to help uphold what their wishes and traditions and beliefs are. We also want to make sure that we can assess for pain at the end of life. When the patient can't speak or relay pain verbally, we need to look for other signs and symptoms of pain. Everything from moaning and groaning, guarding. If as you're moving them, they might not even be awake, but maybe they move their arms towards an area of their body. Not moving parts of their body, resisting care, rapid heartbeat, diaphoresis, changes in vital signs. All of those things may be ways that individuals exhibit pain. If your patient is from a culture that you're not familiar with, it would be great if you could talk to a family member if the patient cannot talk with you and figure out how that person exhibits pain, what they do when they have pain, and how they handle it so that you're better able to assess for pain. And we'll talk more about pain assessment and also some of these drugs in the next lecture. So we do know that when people don't get relief from pain in the dying process, that it may hasten their death. It certainly causes psychological distress for the person, and it may also with the family members, and it's associated with many negative outcomes. When we administer medications, we want to really think about this in a stepwise manner. You want to start with non-opioid analgesics. So those are ibuprofen and Tylenol first. And then we might add an adjuvant, I can't talk today, obviously. Adjuvant therapy. So we could add an antidepressant if the pain is neuropathy pain. We could add some other non-pharmacological treatments like turning, massage, aromatherapy. But we want to make sure that we add that. We also need to balance. So I could give Tylenol at 8 and ibuprofen at 11, and then Tylenol again at 1, and bounce that back and forth, and then put the adjuvant therapy in between there as well. And so you might stagger medications to get more effective pain relief. You want to make sure we can keep their pain fairly level and not get too intense before they need something else. Otherwise, they're going to be super uncomfortable and miserable, and will have a much harder time getting control of their pain. When we go to step 2, we can start to use some weak opioid analgesics. In addition to the non-opioid analgesics and the adjuvant therapy. So weak opioid analgesics, low doses of codeine, or hydrocodone, that's all within that codeine family. When we move up to step 3, we're going to use more potent analgesics. We could use things like fentanyl and higher dose opioid medications. It doesn't matter if they develop a tolerance or become addicted, because the end result for this person is death. There's also a lot of different routes we could use for individuals, but we're going to really work hard at not using um, IV and sub-Q medications. We don't want to do that because it is invasive for our patient, and it makes it harder for our patient to tolerate. They get stuck a billion times. It's just one more source of pain for them. So think about topical, rectal, transdermal patches, oral when they can. We could use inhalation, and we could use sublingual. And when we get down to it and our patient's unconscious, sublingual will be and rectal will be our best methods to get their pain under control quickly. Other symptoms that we need to make sure we treat, everything from constipation to shortness of breath. We still don't want them to get decubitus ulcers. If they're anorexic, that means they don't feel like eating. We could help resolve that. We can help with cough, nausea and vomiting, and fatigue at different times. And signs of imminent death, we have the biggest signs that you're going to see. There's lots of signs here, like sleeping most of the time, stopping to eat, bowel sounds become hypoactive, and no urine, those types of things. But when we start to see that the heart rate is slowing, that the skin is cool and clammy and progresses to mottled, the mouth is drooping, and they're drooling because they can't swallow their secretions anymore. And then when they start having periods of apnea and very moist, rattly breathing and slow, that's pretty much imminent death, which means at any time. Of course, you always see people rally and then do well for a while. That can always happen. Or sometimes they'll wake up and talk to family members for a little while, or they'll wait for a specific event to occur. And then somehow after that happens, they pass. Postmortem care is difficult, but it's essential, and it's really the nurse's job to make sure it's done well. We have a very high responsibility to make sure that we identify the person, that we get their belongings to the right people, but also that we are showing that individual and the family that the person was cared for and respected. So shortly after death, it's very common for patients to be incontinent of urine and stool. We'll want to clean that up, get them in a nice clean gown, clean sheets, attend any spiritual and religious practices a family might have, help ease their anxiety. If we just do some of that initially, then before we get them ready to go to the morgue or the funeral parlor, we'll bathe the person and change the sheets. They may have been incontinent again, so we want to take care of that. Remove any IVs, tubes, catheters, unless it's contraindicated. So any case that's going to need to go to the coroner, we'll leave those tubes in place. We'll drain the catheter, for example, but we'll disconnect the bag, leave the Foley catheter in place, either clamp it off or fold it in half and rubber band it tight together so it won't leak. And you wouldn't have a lot of leakage, but you might have some. Same with IVs, just saline lock off. I guess you don't have to put saline in them, but just lock off all tubes, leave them in place. And then position the person on their back with a pillow and a blanket pulled up about mid-chest, and cross their hands either over their abdomen or leave them straight at their sides. And then advanced directives again. Remember that the healthcare proxy or durable power of attorney is a legal document that allows others to make healthcare decisions for you when you can't. It should go into effect when you can no longer make these decisions for yourself, so you lose consciousness and can't make the decisions. Your cognitive abilities are gone, so you can't make those decisions, or you're unable to somehow communicate your wishes. A living will is a legal document that describes what treatment you wanted at the end of life. So it may include acceptance of all life-saving procedures, some life-saving procedures, or maybe just one or two. So you could do rescue breaths only, you could do drugs only, CPR's fine, maybe no feeding tube, but IV fluids are okay. It makes it a little more complicated, but all of those things are fine to designate. You need both a living will and a healthcare power of attorney in case you cannot communicate your wishes. And then occasionally persons will request for a hastened death process, like assisted death, or may have heard it called assisted suicide at some point in the time. These are reserved for persons who have advanced suffering. Always important to validate the person's feelings and consult with the healthcare team and not make a decision on your own. There are several legally accepted ways that any adult can take to hasten their death, from voluntary withholding nutrition, terminal sedation, or withdrawal of life support. In the 80s, it was very taboo, and Dr. Kevorkian had started some of this and was jailed for his efforts. And now there are about half the states in the United States that have laws that allow assisted death or assisted suicide. So you need to explore that in your state. And withdrawal of life support doesn't necessarily mean it's an assisted death. In all cases, it just depends on the situation and the scenario. I think the hardest thing when you have a death is that you have to be to some point the strong one and help the family grieve, but you also need to grieve yourself. So while others are grieving and you're supporting those, even if you just sit and listen, that's enough. You don't have to do anything else. Just sitting there and being with them is fine. But take time for yourself and your team to process. Make sure that you and your team have debriefing sessions so that you guys can stay healthy as well. And if you ever have additional needs, that you can contact the employee assistance programs, or as a student, the Student Health Center and mental health resources that are available to you. So this is the end of this lecture, but we'll have another follow-up lecture next week that'll go into a little bit more detail. This is just an overview lecture.